Okay, thank you for a nice introduction. And my topic will be about lithium. And as the title states, lithium is both the lightest metal and also the therapeutic agent in pathological emotional instability. So the name lithium comes from the Greek word lithos, meaning stone. And lithium was one of the three first elements, together with helium and hydrogen, to be synthesized in Big Bang. But due to several other processes, the abundance of lithium is much less than these two elements nowadays. Lithium is found in various salts in nearly all rocks and hydrated in many mineral springs and seawater. Trace amounts of lithium are found in numerous plants, plankton, and invertebrates. There are little less in vertebrate tissues and body fluids. Lithium is an element of the first group of Mendeleev table, and it has resemblance with monovalent cations such as sodium and potassium, in a way of similarity of hydrated radius, but due to its high charge-to-radius ratio, it has some resemblance also with divalent cations such as magnesium and calcium. And due to this interaction mostly with cations and all other things, lithium exerts profound influence on many biological functions such as enzyme activity, metabolism, and active transport processes. And the effect of lithium ion on biological systems is depending on its concentration. Lithium is not a real trace element because there is no illness with lithium deficiency. And the concentration for lithium, which is used for therapeutic purposes, for example, in bipolar mood disorders, it may exceed nearly 1,000 times its endogenous level. However, some behavioral effect of lithium may be found with similar concentration as in body fluids, such as concentration of lithium in drinking water, that will be shown later. Historically, the great Roman physician, Soranus of Ephesus, in his book, recommended that people with nervous disorders should drink alkaline mineral waters. It transpired later that these waters were containing significant amount of lithium ion. But the first discovery of lithium as a chemical element was due to the Swedish chemist, which was working in a laboratory of Berzelius. This was Johann Arvidsson, and he obtained lithium carbonate from the mineral petalite occurring in Swedish island Uto. Then, the history of lithium use in 19th century was due to Alfred Garrod. He was the father of Archibald Garrod, the founder of the term inborn error of metabolism. But this, Alfred Garrod, introduced lithium for the treatment of gout and other rheumatic diseases in which some excess of urate deposit may occur, because it was shown in this time that lithium urate was among the most soluble urates. And then Carl Lange, the great Danish physician and scientist. And this Carl Lange is the co-author of the first theory of emotions, so-called the James Lange theory. But this Lange, he started in Copenhagen to use lithium salts in the treatment of recurrent mood disorders, mostly for periodic depression. He treated this periodic depression as a good of the brain, so lithium should just be kind of soluble, could resolve this urate deposit in the brain. But it was not until John Cade, an Australian psychiatrist from Melbourne, he gave lithium after performing the experiments on Guinea pigs. Then he took lithium himself just to find out whether it is toxic or not, which would be and then he gave lithium to 10 manic patients and obtained remarkable therapeutic result, which was published in 1949 in his famous publication in the Medical Journal of Australia. And this publication may be regarded as the beginning of modern clinical psychopharmacology. It preceded by 3 years the first publication of a French psychiatrist about chlorpromazine as an antipsychotic drug. Of course, the way lithium was introduced in psychiatry just after experiments of guinea pigs, then taking lithium himself, but the investigators to find out whether it was toxic would be considered now as a complete violation all clinical practice, all good clinical practice. But still, and then in his first publication, John Cade even argued that the effect on patients of lithium on patients with pure psychotic excitement was so specific, so spectacular that according to Cade, it may lead to speculation if is there any deficiency in the body of lithium ion in the genesis of this disorder. Second, commemorating the great discovery of Cade was more than 50 years later. In 2003, there was a play, Dr. Cade, which scenario was written by Neil Coe, the former Justice Minister of Victoria, still in Australia, who himself used lithium for therapeutic reasons. There is a variable of actors at Sydney premiere. And also, there was, in the next year, there was film Trouble Mind, The Lithium Revolution, which was based on interviews with John Cade's sons, his patient, and other people connected with him. And this film won the main praise at the International Vega Awards for Excellence in Scientific Broadcasting. And he's the actor playing one of the first manic patients treated with lithium, which was called Monkey. And the name and the next great name with lithium research was Danish psychiatrist Mogens Coe. And in 1954, he performed the first placebo-controlled trials of lithium efficacy in mania. 70 years ago. So doing this placebo-controlled trials was really a great deed. And also Mogens Coe performed the first determination of lithium in blood and cerebrospinal fluid, what would make the path to routinely determining of the lithium in blood. And there is very important date in 1963. English psychiatrist Geoffrey Hartigan published the first time the article in British Journal of Psychiatry pointing on lithium efficacy in preventing recurrences in bipolar and unipolar mood disorder. There was 3 years observation, and most of patients, both with manic depressive illness and also in recurrent depression, had no recurrences while on lithium. There was also a time where lithium was a scientific periodical. I was here on the editorial board because generally I embarked on my journey with lithium something like 40 years ago, and I'm still on it. And I will mention some of my contribution to this. So, the lithium can be termed the first mood-stabilizing drug based on its antimanic activity, shown by Cade, preventing recurrences of both mania and depression, but also lithium has some kind of antidepressant activity, both as monotherapy and augmentation of antidepressant drugs. So, mood-stabilizing drug should act therapeutically in mania and in depression, and also prophylactically in mania or in depression, and there are now 2 generational mood stabilizers. Lithium is a prototype of the first generation, but now there are also the second generation, including most of atypical antipsychotics and also lamotrigine. The first generation is lithium, valproates, and carbamazepine. There is very specific group of lithium treated bipolar patient called as excellent lithium responder. There are people whose life has been a remarkable change due to lithium prophylaxis. In these people, there is a total cessation of disease expression during lithium administration up to 30 years or more. It's just constitute of 1/3 of lithium-treated bipolar patients. These patients have some classical characteristic, distinct periods of complete remission between episodes, moderate frequency on the episodes, similar course of the illness is also found in the offspring, and these excellent lithium responders constitute of endophenotype of bipolar mood disorder for molecular genetic studies. We also identification of the percentage of this excellent lithium responders, and both patients entering lithium in 1970, 10 years observation, and also patients entering lithium in 1980, also 10 years observation. The percentage was similar, 1/3 of lithium-treated patients. We have spectacular examples of patients with more than 30 years of lithium observation on monotherapy of lithium with very, very good both psychiatric and also somatic effect. So, the first indication for lithium nowadays is treatment of bipolar mood disorder and mostly prophylaxis of recurrences. The second is augmentation by lithium antidepressant drugs. And augmentation of lithium of antidepressant drugs now remain the best documented strategy of treatment-resistant depression. So adding lithium to antidepressant is now the best documented strategy for assist this kind of depression. We also have had some works on it, and lithium may affect cognitive functions. And in clinical meta-analysis, which was probably done with different plasma lithium levels, so there was evidence for both neuroprotective or neurotoxic effect of lithium, but in experimental studies it's now unequivocally enhancement by lithium, learning, enhancing neuroplasticity, and it will be also reflected in other studies. And we found that this group of excellent lithium responders, with 1/3 of lithium-treated patients, have a normal cognitive function, a normal plasma BDNF level, which is kind of a marker of bipolar illness. So in this kind of illness, lithium may cause complete normality to all aspects of the illness. It's just similar as in healthy subjects. Another very interesting effect of lithium is antiviral effect of lithium, and mostly anti-herpes virus infection. It was found by Birmingham investigators in 1980 that lithium inhibits herpes virus replication. Several mechanisms were proposed, and we, in the collaboration with Dr. Amsterdam from University of Pennsylvania, Philadelphia, we did some retrospective study about lithium prophylaxis as recurrent labial herpes infection. And what we found that the herpes recurrences were reduced by 2/3 during lithium treatment. These labial herpes recurrences, of course, in people which had this labial herpes before. And the percent of reduction was also related to plasma and erythrocyte lithium levels. So the more lithium concentration was associated with greater reduction in this herpes recurrences. In 1/3 of this patient, there was complete disappearance of this herpes reduction. We also had some experience with the lithium succinate ointment for topical treatment of herpes infection, which was kind of comparable with acyclovir, which was now routinely used for this indication. And I put some resume of this antiviral and immunomodulatory effect of lithium in the article in Pharmacopsychiatry in 2000, that I suggest that this effect of lithium may also play some role in its psychotropic action. A very spectacular effect of lithium is its effect of suicidal behavior. And all meta-analysis, all recent meta-analysis, it was found that lithium-treated patients have several times lower risk of both committed suicide and attempted suicide of self-harm. In some other papers, it was stated that lithium treatment reduces mortality risk to the level of general population, and most significantly after 2 years of administration. And lithium has the best evidence out of all mood stabilizing drug to be anti-suicidal. And this is a recent paper in British Journal of Psychiatry, just in the last month, when the correlation in Austria was analyzed between lithium amount in drinking water and suicide mortality. The first author is of Austrian, but he has a Polish-sounding name, Kapusta. But it is analysis in Austria that he found that the bigger lithium level in drinking water, the less suicidal mortality. Here are the correlations. So the spectrum of lithium action is prevention of manic depressive recurrences, therapeutic and augmenting effect, anti-suicidal effect, antiviral effect, and now the neuroprotective effect. This neuroprotective effect is connected with the effect of lithium on the brain, so probably the changes in transport enzyme activity, metabolism are exerted to the cells of brain structures responsible for emotion. There were some hints that lithium may act on neural cells by effect of transport across membrane. When I was in Philadelphia in 1977, we are in the group of investigators. We were investigating the mechanism of lithium transport on the model of erythrocytes. So we found that the main factor of lithium transport and of the amount of lithium in the cells is so-called counter-transport lithium sodium. And it was a paper in 1977 that the activity of this lithium sodium countertransport is negatively correlated with erythrocyte lithium ratio, and that of course it imply that transmembrane cation transport may be abnormal in mood disorder. And now come back to this neurotropic and neuroprotective lithium action. There are several mechanisms of such action. Generally, lithium is augmenting neurogenesis and inhibiting apoptosis, and the main biochemical mechanism of such action, there are several. It's inhibition of phosphatidylinosity system, inhibiting protein kinase C, also inhibiting glycogen synthase kinase 3 beta, increased expression of neurotrophins, mostly BDNF, and also increased expression of B-cell lymphoma. Here there are some places where lithium is acting that are shown. Probably the BDNF, this brain-derived neurotrophic factor, the most important neurotrophic, would be the target of lithium action. In all experimental studies, lithium is stimulating the BDNF system, and also in clinical studies, lithium is increasing serum BDNF, and what we find that excellent lithium responders have normal serum BDNF. We found several investigations about the pharmacogenetics of lithium as far as brain-derived neurotrophic factor gene is concerned, and also the interaction between serotonin transporter and BDNF gene in lithium prophylaxis. And what we found that there is a great interaction between these two genes. And for example, it can predict also the response to lithium. For example, as you see this non-responders, if you have S allele of serotonin transporter and Val genotype of BDNF, so it's nearly 70% probability that the effect of lithium will not be optimal. In the recent genome-wide association study, the strongest signal out of something like nearly a million of gene polymorphism was associated with the gene of diacylglycerol kinase, which was connected with phosphatidylinositol system, this main intracellular target of lithium action. There was international group for the study of lithium-treated patients, and National Institute of Mental Health formed 2 years ago, aimed to do genome-wide association study in more than 1,200 lithium-treated patients, and it is now underway. And I was in the group, on this initiative group, the first publication about this international consortium of lithium genetics. It's a Conley gene. And now probably the very interesting aspect of lithium neuroprotective effect, which was now resembled in neuroimaging studies. So there was first study of Moore in 2000, but it was kind of provocative. But now there are some really well-evidenced studies. There is increase in gray matter of prefrontal cortex after lithium treatment. So there is increase in gray matter it's a total gray matter. It's prefrontal cortex gray matter, and also it's just subgenual prefrontal cortex gray matter. Also, lithium may have augmenting effect on the volume of hippocampus, because there are also several papers showing an increase of hippocampal volume in lithium-treated bipolar patients. And also this second study showing a larger hippocampal volume in lithium-treated bipolar patient compared with non-lithium treated. This is the picture of this. So, this neuroprotective effect of lithium just prompted the possibility that lithium may be kind of beneficial in neuroprotective, in neurodegenerative diseases. And however, the results of experimental and clinical studies are not compatible. For example, in experimental studies, lithium has such an action which may imply its good effect in Alzheimer's disease. For example, lithium inhibits glycogen synthase kinase 3-beta, which is the main enzyme connected with the metabolism of amyloid protein and tau protein phosphorylation, what was found in experimental studies. And however, the clinical studies, as you see, the two first studies were negative, but the two other studies, including the last one, were positive as lithium, and the last study was positive that in terms that in patients with mild cognitive impairment after lithium treatment, there was a better performance of cognitive scale and attention, and also decrease in CFF tau concentration. There was a great Danish central register, which was a good point to make analysis for the effect of lithium on the Alzheimer's disease. So there was a comparison of lithium prescription of person with lithium prescription, and what was found that people continuing lithium had the risk of dementia similar as in general population. However, in people taking anticonvulsants, the risk of dementia increased with the duration of this treatment. And also, lithium treatment of patients with bipolar mood disorder. So lithium treatment was connected with a less frequency of dementia, and treatment at another drugs were connected with more frequency of dementia. In Huntington disease, there are also experimental studies showing that lithium may have some good effect, but no clinical studies were done. And also in amyotrophic lateral sclerosis, there are some promising data coming from experimental studies, but clinical studies were not unequivocal. There was one paper with showing delay of disease and with lithium, and one study showing the lack of such effect. So perhaps interesting will be the lithium treatment and some celebrities. There were some books published in 1949. The first is Nobel Prize winner Salvatore Luria for his research of bacteriophages, and his treatment with lithium was described in the book A Slot Machine, A Broken Test Tube, an Autobiography. And probably second was Patty Duke, movie star, which was the youngest Oscar Prize winner for her role in the movie The Miracle Worker, and he described her lithium treatment in the book Call Me Anna in 1987. One of the most outstanding American poets of the 20th century, Robert Lowell, was treated with lithium for the last 10 years of his life. Now it's a cover of the record by Nirvana, in which Kurt Cobain performed the word lithium. It is said that Cobain suffered from bipolar mood disorder and died a suicidal death, and the title of his work refers to a therapeutic remedy which Cobain knew but never tried using. Perhaps the great celebrity connected with lithium is Professor Kai Redfield Jamieson, which is co-author of the Bible of the bipolar mood disorder called Manic Depressive Illness, together with Fred Goodwin. And she was an author of numerous books, such as Touch with Fire, about artistic creativity of bipolar patient, The Night Falls Fast, about the suicide and exuberance. And here he described her lithium treatment in the book Unquiet Mind. The book, which was translated into several languages, also was translated into Polish as Niespokojny umysł. And here are two editions of this famous textbook, Manic Depressive Illness, from 1990 and 2007, where Kay Jemison is the co-author with Fred Goodwin. And after 60 years, after introducing lithium in contemporary psychiatry, there was a special issue of neuropsychobiology appeared. I was the main editor of, and in the editorial I just reiterate the quotation from John Cade, and also in the review article, which is now in World Journal of Biopsychiatry, I presented the state of art of lithium in neuropsychiatry for this year. And just to end up with is my picture with Kay Jemison with some conferences, and also my book about the phases of manic depressive illness, where lithium is a great element of this book. Thank you very much.
Well, on behalf of everyone, I want to thank the two speakers for a really interesting talk. We have a few minutes to raise issues, which I think some fascinating issues were brought up. Are there questions or comments? Of course.
How would you comment this fact? There was a study that when lithium is stopped abruptly, the rate of suicidal behavior increases much higher than prior to introducing lithium, and then a year later it is the level before introducing lithium. How would you explain that?
It may be kind of rebound syndrome, which is very common in several other phenomena. I think that could be called as rebound syndrome. Yeah.
Other comments or questions?
I have a little of a philosophical comment, because we've been hearing these talks where which were trying to convince us that really the physical has quite a bit of influence on the way the mind operates. So we're seeing that a lot of the phenomena which were normally relegated to the dualism, mind and body, are now seen as a function of a purely physical. So my question to the psychiatrists will be if they really perceive the mind-body dualism as an obstacle to perform psychiatry these days. Is it really a philosophical statement which has to be done away with, or is it still of any help? Because what we're seeing is that certain philosophical standpoints, as we were seeing Descartes before, were a basis for a paradigm in psychiatry, but now it seems to be going away. So do psychiatrists really see the Cartesian dualism now as an obstacle to performing psychiatry?
Well, it's a very interesting question. I think I should reflect a little bit more about that. But if it is an obstacle, I think that still with that dualism, the progress in the research in psychiatry is not as huge, and in other fields of medicine. And I think that unification, it means recurrencing from this dualism, may be more helpful in our understanding of human being, in our understanding of our work, and I think it will be more helpful to integrate. I don't know if second psychiatrists can agree.
I don't think that the dualism exists now in psychiatry. We both see the elements of the psychiatric pathogenesis as the interaction between biological and environmental or psychological factors, and also in each patient we administer both biological and psychological therapy. In several, in various nosological entities that are in different proportions, but there is no such single entity where we just administer only biological or only psychological therapy.
We believe, I think, that the mind is, of course, a function of our brain, but also it is embodied brain, strongly connected to the body and embedded in environment. And we cannot understand human being without integrating those entities. It's what I think as psychiatrist.
Okay, we have two more questions.
I'm not a psychiatrist, but I'll answer in a different way, which is, even though I'm a neuroscientist and I pretty much accept a material basis for the things we call mind and behavior, when I go home and I pet my cat, I treat it like another creature, and I talk to it and respond to it as if it has a mind or a soul or whatever else, even though I don't believe it does. And when I deal with my wife or my son, I treat them as people rather than as brains or neurons or anything like that. So I think we have to distinguish reductionism from levels. There are different levels of explanation, and each level is a proper and acceptable on its own. So the mind and behavior still exist even if it's based on the brain. And I think when we deal with people, we deal with them as people, not as brains. So I don't see too much of a conflict, but I know it's a tough problem.
Well, I think that looking for the development of biological psychiatry and psychological or analytical psychiatry, when you look for biological psychiatry, you can see there's a steady progress, and each step really is just based on other steps. So really we can see a logical progress in biological psychiatry. In contrast, the analytical psychiatry, there are just bright ideas that appear, disappear, there are some other things. Sometimes it's a very good connection in one moment, but I see a fundamental difference in the development of those two branches of psychiatry. Biological psychiatry is a real science, and still the analytical psychiatry has no value of science, at least just in the terms of what we think, what we biologists think that science is. It doesn't fulfill the criteria of science, I would say.
Yeah, of course I agree. And I must say that what I think about analytical psychotherapy, it did a lot of good, very wonderful ideas, and this is great psychotherapy. But on the other hand, it did a little bit stopping of the progress of psychiatry in states in the 50s, 60s, and so on. However, we must remember that the art of psychotherapy, it is not only psychoanalytic psychotherapy, it's also, for example, cognitive behavioral therapy. And maybe this cognitive behavioral therapy, the results, the effectiveness of this cognitive behavioral therapy has much more evidence-based data about efficacy, and it is much stronger connected to cognitive sciences.
Okay, but still, neuropsychoanalysts try to explain some ideas, psychoanalytic ideas, and some terms in biological terms, and definitely one of the fundamentals of psychoanalysis that the early experiences may have profound impact was now confirmed on biological level.
Yeah, for people who are interested in that, and I think it is really a fascinating story, there is a great book about psychodynamic psychotherapy by Glenn Gabbard, and there is a big chapter about neurobiology of analytic psychotherapy, just for information.
Well, please join me in thanking our two speakers for a wonderful session.